is just oxygen at the right time, at the right place, and that's the key to that. But now I'm going to try the screen share before we go to the next speaker. So moderator is you. I'm going to start the screen share. If I have a problem with it, then you can call on the next speaker. So hold on, please.
Now, a breakthrough in the treatment of sickle cell disease could mean the difference between life and death for millions of people around the world. US-based Dr. Sota Omoigui, a revolutionary work employs a preventive approach using home oxygen therapy for patients. Arise correspondent Turaya Farouk reports.
Imagine a world where sickle cell patients can live without the constant fear of crisis and pain. Dr. Sota Omoigui's pioneering research has made this a reality. The conventional approach and what hospitals around the world do currently is called the MAD paradigm. It focuses on treating patients in hospitals after they experience an irreversible sickle cell crisis. But this often leads to severe pain, cell damage, multi-organ failure, and in many cases, death. Dr. Sota Omoigui has a different approach. His revolutionary at-home oxygen therapy champions preventive measures tackling crises before they begin.
So the solution here is to prevent the crisis so the patient does not even get to the hospital, the cells do not even die.
In his research, within 30 minutes of the onset of a crisis, in what he calls the golden half hour, the sickling of the red blood cell is reversible by inhaling oxygen or reoxygenation.
The reason why modern medicine missed this solution was that by the time patients got to the hospital in a crisis, they were already in an irreversible sickle cell crisis. Their cells could no longer be restored by oxygen. So doctors thought oxygen did not work.
It's a shift from a reactive treatment approach of the last 100 years in modern medicine to a preventive approach. Patients and physicians are empowered with knowledge to predict and manage the disease. Some medical practitioners have adopted this new initiative in their clinics, citing the remarkable effectiveness of the approach in their patients.
If you're a scientist and you understand the rationale for the use of oxygen in the first 30 minutes of a sickle cell crisis, every last one of them recovered. Many of them without any other treatment, just oxygen, and they're better and they go.
I've not seen them back in my office anymore since they acquired the oxygen. They'll not be coming for hospital visit. I did administer it myself. They did it at home. Okay, it's a home administration. Okay, so they administered there, and they called me, and they are very happy about the whole situation. I've never had any results in management of patients, as much as what I've had with this, home oxygen therapy.
The procedure allows patients to manage their condition from the comfort of their own homes through the use of an oxygen concentrator or a cylinder. His research has shown a significant reduction in sickle cell crisis with a 90% effectiveness rate.
0% hospitalizations, and that right there alone was amazing, because it really is, it's just really, it's not okay, and it's painful and it's heartbreaking. And not only have we had less challenges, no challenges, because the oxygen concentrator works and I got a backup just in case, I feel more confident. Seeing her be able to go from 45 days of missed school to 15 days of missed school And, seeing her be able to get back in there in school faster and not have to like overcome like such a big hurdle, like, oh, I'm coming back after weeks or coming back after being in the hospital. Seeing her jump right back in there, a lot of pride. And as a mother, you can try to fix everything, and I can't fix that. So it's been heartbreaking to me to see that and to see someone I love melt away from me.
Within 1 hour, 30 minutes of being on oxygen, the crisis went from a 7/10 pain to 1/10. So like, I was really shocked that, okay, what is this discovery? This is magic. I was not given any pain reliever, no fluid yet, just the oxygen. Since I got the oxygen concentrator, it really helped me to relieve stress. I have better quality sleep, because I use them when I want to sleep. It has really helped me. I've not had crisis since then. It's been 4 months now. Yeah, I've not had crisis since then.
This groundbreaking discovery is set to revolutionize the treatment of sickle cell disease. By adopting this preventive measure, patients with sickle cell disease can experience improved outcomes, reduced hospitalizations, and an enhanced quality of life. Thuraya Farouk, Arise News.
Let's talk about sickle cell disease. For literally thousands of years, it's carried this devastating complication, the vaso-occlusive crisis. It's an agonizing, unpredictable event, one of medicine's oldest and toughest challenges. But what if the answer wasn't some futuristic drug? What if it's been hiding in plain sight this whole time? We're going to dive into a story that could flip everything we thought we knew on its head. Okay, so this is the official view from the top. You've got a major executive at a pharmaceutical giant, and in 2019, he's calling these crises unpredictable. That one word, that says it all. It frames the entire medical approach, which has basically been, wait for the disaster to strike and then try to clean up the mess in the hospital. But here's the kicker. What if that fundamental assumption is just wrong? What if these crises aren't so unpredictable after all? What if the clues to stopping them cold have been sitting right there in published scientific papers for decades, just waiting for someone to finally connect the dots? To really get this, we've got to rewind a bit, because the central argument in the material we're looking at today is that the key pieces of this puzzle aren't new at all. In fact, they've been around for a very, very long time. Okay, check out this timeline. This is pretty wild. All the way back in 1930, researchers knew that sickling was a reversible process linked to oxygen. Fast forward to the 90s, and you get more reports, even a clinical trial showing, yep, inhaled oxygen can reverse it. Then in 2015, a team at MIT actually films it happening. The evidence was piling up for decades. You can unsickle these cells with oxygen. So the big question is, why wasn't this being used to stop a crisis before it even got started? Right, so this is the absolute key to understanding everything. A sickling event isn't just one big catastrophe. Think of it as a two-stage process. First, you have this reversible stage. It's triggered by low oxygen, and this is the crucial part, if you give the cells oxygen back in this window, they can pop right back to their normal shape. But if you wait too long, you cross a point of no return. You enter the irreversible stage. The cells are permanently damaged, they start blocking up blood vessels, and that's when you get the full-blown organ-damaging crisis that lands people in the emergency room. So you'd think with all those clues pointing to a two-stage process, the modern approach would focus on that early reversible stage, right? Well, nope. Instead, the pharmaceutical industry has been looking elsewhere, and according to our source material, that path has led to a dead end, with one high-profile failure after another. And man, this table just lays it all out. Look at this. We're talking recent history, 2023 to 2025. Major drugs from giants like Novartis and Pfizer yanked, withdrawn, failed trials put on hold. Atigovio didn't work any better than a sugar pill. Oxbryta was actually linked to an increase in crises. Billions of dollars were poured into these drugs, all of them designed to fight the fire after the house was already burning down. And this quote, this just nails it. It basically says that by trying to fix things way downstream, all these companies were completely ignoring the initial trigger. They were missing that first mile, that initial drop in oxygen that kicks off the whole reversible sickling process in the first place. So if that approach was a dead end, what was the answer? Well, this is where translational researcher Dr. Sota Omoigui enters the picture. He's the one who looked at all those century-old clues, saw the modern failures, and connected the dots in a way no one else had, proposing an idea that was, well, radically simple. He came up with a concept called the golden half hour. It's so brilliant. The idea is this. There's a critical 30-minute window right when the symptoms first start, when the sickling is still in that reversible stage. His hypothesis was that if you could hit it with oxygen right then and there, you could stop the entire cascade before it ever becomes irreversible. The missing piece of the puzzle wasn't a miracle drug. It was a stopwatch. It was all about timing. And that brings us to the whole solution, which just completely upends the old way of thinking. It's not about racing to a hospital. It's about stop the entire cascade before it ever becomes irreversible. The missing piece of the puzzle wasn't a miracle drug. It was a stopwatch. It was all about timing. And that brings us to the whole solution, which just completely upends the old way of thinking. It's not about racing to a hospital. It's about giving the patient the power. It's the right tool, simple inhalational oxygen, in the right place, their own home, used at exactly the right time, the second they feel symptoms, inside that golden half hour. It's a powerful theory, right? But you've got to test it. Does this simple, proactive, at-home idea actually work in the real world? Well, let's take a look at the data they gathered. So a study was set up with 98 patients in Nigeria. They tracked everything, daily symptom logs, hospital visits, you name it, comparing their lives before they had home oxygen to their lives after. And the results that were reported, well, they were nothing short of dramatic. First up, hospitalizations. For the patients who used oxygen at home the moment a crisis started, the study found a 79% relative reduction in hospital admissions. Just let that number sink in for a second. 79%. And it didn't stop there. The data also showed an 80% relative drop in the need for blood transfusions. That's a huge deal, since transfusions are a common but also risky treatment for severe crises. But what about the pain itself? I mean, that's at the heart of every crisis. This chart is incredible. It shows the average daily pain score out of 10. Before the home oxygen, it was over a 5. After they started using it, it plummeted to just 1.59. What that means is they were turning these severe, agonizing crises into mild, manageable events, or even stopping them altogether, often in less than an hour. You know, the clinical numbers are one thing, but this is what it's really all about. Patients themselves were reporting that 80 to 90% of their crises were either completely prevented or stopped dead in their tracks. They talked about their quality of life just skyrocketing, better sleep, more mobility, and maybe most importantly, a massive reduction in the constant fear of the next crisis. They weren't just victims anymore. They were in control. So, what does this all add up to? If this approach is as effective as the study suggests, we're not just talking about a new treatment. We're talking about a fundamental, ground-up shift in how we manage sickle cell disease, a whole new paradigm. And this slide just sums it up perfectly. The old way, the 100-year-old way, is reactive. You wait for the irreversible damage to set in, you rush to the ER, and you hope for the best. It's damage control. This new model is completely proactive. It makes the patient and their family the first responders. It gives them the power to stop the crisis from ever even happening. It's prevention, not just treatment. You know, it takes a certain kind of mindset to see a solution that everyone else has missed for a century. This quote from the discoverer, Dr. Sota Omoigui, it gives you a real window into that mindset. It's not about chipping away at difficult problems, but about taking on the ones everyone else has written off as impossible. Which leaves us with this final massive question. For a medical mystery that's 7,300 years old, a problem that has defeated billions of dollars in modern research, could the answer really be this simple? Not some complex gene therapy or designer drug, but a treatment we've had for over a century, oxygen, just applied with a new understanding of place and timing? It makes you wonder what other impossible problems have simple solutions just hiding in plain sight. Today, we're digging into a medical mystery that's almost a century old. How could a simple, life-changing solution for sickle cell disease be overlooked for decades? This isn't just a story about a discovery. It's about finally ending a lost century of suffering. So listen to this. This is what a top executive at a major pharmaceutical company was saying just a few years ago.
Now, a breakthrough in the treatment of sickle cell disease could mean the difference between life and death.
I'm a hematologist, a clinical hematologist. I've been taking care of sickle cell patients for over, 3 decades now, and I think I'm in the right place or position to be able to talk to you between what I used to see before and recently, the past 1.5 years, with my new experience with the new discovery, oxygen concentration machine or home oxygen therapy or early home oxygen therapy. That's one of the, mainstay in the protocol, the management protocol of sickle cell disease. And it's been a wonderful experience. And I used to have so many sickle cell patients in my clinic, not less than 15 in a month. And they come in, of course, sickle cell patients working, they don't work in, they come in crisis. And they, of course, we always try to do our routine things, analgesic, rehydration, and the place and try to find out the cause, treating malaria, and of course, giving antibiotics and so on and so forth. We found already, no matter what you do, the crisis lingers on for a few days and before going. And they found out that depending on what the cause is, they might have, might have a need to be admitted in several occasions or most of the time. But recently, when I just stumbled on the website and I read about Dr. Sota, the discovery of oxygen therapy, and over the years, I've known that oxygen plays a very important role in the management of sickle cell disease. And, whenever they come in, we always put them on oxygen. And we found out that the effect we expect actually, it's just like a gradual effect. And later I got to know most of the time that this oxygen at the time we applied them in hospital does not actually stop the pain, because whatever that has been responsible, that is responsible for the pain is already in existence, and the oxygen cannot take care of it until the body takes care of the cause, which we already know. And I don't want to go into the pathophysiology of sickle cell crisis, but we've discovered, that low oxygen tension plays a very important role in sickle cell disease over the years, and that has assisted our use of oxygen. But the challenge we have been having is actually we have been applying the oxygen at the wrong time. But when I saw this I read the article, on the discovery, I see that is something that has to do with timing, that actually these sickle cell patients can, sickle cell, sickle red blood cells can actually be reversed, when they sickle under low oxygen tension, that if you're able to get to them within the first 30 minutes, about 30 minutes to 1 hour, actually reverse them back to the normal shape and they begin to function normally. And that was the main point I saw. And actually I started, of course, in the hospital environment, you cannot use it. You cannot achieve that kind of thing. And so what I'm trying to do was that we're trying to encourage some of my patients to acquire it, and they did. And at the end, they were able to, I noticed that they were getting results. They were getting results, telling them each time they felt like had the symptoms of, had the, kind of felt like they wanted to have it, they should use oxygen at home. And they did. And I found out that their hospital visitation reduced drastically. And even when they came in a situation where we could manage them easily, and they would just go home that same day. And frequently I noticed that the number dropped and eventually even zeroed. And the only ones I still see now are the ones that are not able to acquire the oxygen therapy appliance. So it's been a very wonderful experience, and I tell you it's great, and that I've been part of this. And frankly speaking, my role, because I now have a very few of them in my practice. I try to do things, as part of the humanity services, in the platform, helping all the warriors, all the sickle cell patients all over Nigeria, all over the world, and contacting me, try to help them get the right oxygen concentration, oxygen therapy appliance, and helping them to also use it at the right time and the right quantity. And they have been wonderful all over. And sometimes when they, some of them, get crisis and they visit the hospital, I help them to also, their doctors, to take care of them effectively, to make sure they are taken care of successfully. And I've been doing that over the years, pro bono, not for fees. And they've been wonderful results. And some of them who always want to rush to the hospital and, during any crisis, they end up not going to the hospital anymore. and calling on me. You see me managing sickle cell patients remotely, having a remote management, effective remote management of this, which is successful. So they won't go to see them not going to hospital anymore, just calling me. I say, okay, do this, and do this. And they get well with the oxygen already on the ground, they're already on the oxygen. I will not tell them what to do again, just add this. And they get well. Unlike before, they would have ended up in hospital and would spend days. And we've also found out that the patients are now better. Most of them are crisis free. And they are not necessarily crisis, but the frequency has reduced, hospitalization has reduced, blood transfusion has reduced. And more people who are benefiting more here, especially the teenagers who are now entering university with the portable oxygen concentration machine. Most of them that are used to, drop out during examinations, and the testimony has been that they all end up taking all the exams, without falling sick because of this oxygen application. It's been wonderful. But I follow them up wherever they are, pro bono. They all have my number. They call me up, and I can, specifically testify the efficacy of this oxygen therapy. And I want to advocate that every doctor should give it a try. It's not a time to make argument. The oxygen is not just what you think. Just use it, and you'll be able to know, you have the experience. So there's nothing to say that this is difficult. Some people have said so many things. I know some of the patients calling me, telling me that doctors are refused to use it, say it doesn't work. But you're not giving it a chance, or so not necessarily it doesn't work. Some of them said that it's not true, it's internet medicine, and some of it, this is not internet, it's real. And so I want every one of us, especially my colleagues, to try and use it. We are the second responders. Now with this oxygen, they are the first responders. The patients are now the first responders, and you see them doing well with it. So I want to encourage everyone. It's been a wonderful experience, and I thank God, that I'm able to witness this in my practice, this new discovery, and it's something that is very, very efficacious. And once you apply it at the right time and at the right dose, and you get the right, the right therapeutic result. So I advocate, and I want to recommend it to everyone. Thank you very much, and God bless.
Okay. Thank you. That was Dr. Ernest Onogu, hematologist based in Lagos, Nigeria, and one of the people who got on board my discovery and applied it on his patients. And I want to say one thing before Dr. Onogu is also going to talk here, is that I'm addressing Professor Grinch. Any doctor still asking for studies means they have not read the existing studies. There are studies upon studies from 1927, Han and Gillespie, 1930s, Scriver and Wow, and Scriver and Wow from Robert Hebel, from Chang, including clinical trials by Zepuski in 2015. They're all in the literature. They've been in the literature for 100 years. They should just go and read it instead of looking for more studies. Read the studies that have already been done. It's as simple as that, and apply it. So this discovery is application of an existing multiple studies that people overlooked. And it's not a new drug. Again, I repeat, it's the same oxygen in the hospitals. It's the same oxygen in the hospitals given at the wrong time. This discovery is about timing and place. It's just as simple as that. And of course, this discovery is coming to disrupt the financial models, both of doctors, of sickle cell foundations, of NGOs, because People who profit from treating the same thing over and over, treating crisis, treating a vascular necrosis, treating leg ulcers. This discovery is going to put a halt to the vast majority of those treatments. So anybody who's not interested is not interested. I've even offered oxygen cylinders to a foundation, in Sickle Cell Foundation in Lagos. They were not interested. So that's all I can say. But the ultimate proof again is the patient, is the timing and the place. That's all what this is the same treatment, the same oxygen, but given in the right place at the right time. That's what this discovery is about. So, but for now, I'll hand it back to the moderator, Isiwa. Who is going to be next?
Next, if Dr. Ugbeye Michael is with us, we'll have him speak. If you are here, please raise your hand just so we can see you.
Dr. Mike Ugbeye, are you here? Raise your hand so we can unmute you, please. Okay, I don't see him here. Okay, so so let's go on to the next person. I'm sure he'll join us before the end.
Okay, in that case, we are going to invite some family members and caregivers to speak to the person.
Wait first. Doesn't Dr. Nogu get to speak first before the family members, or is he after?
He'll be speaking subsequently after the family members and
Okay.
caregivers.
All right. Thank you. All right. So let's see which of the family, you can call their names one after the other, and they should put their hands up if they are here. You can start with the first one, Isiwa.
So first, let's see if Mansour Bello is present. You can start there.
I know it was here earlier. I'm not sure if it's still here. Okay. If he doesn't put up his hand, then you can go to the next one.
Is Moses Adedeji with us this afternoon?
If you're here, please put your hand up so you can be called.
Okay, noted. I see Esther Tabawe with us this afternoon. Please, if you'd like to speak, we'd love to hear from you.
So can you unmute her, please?
Yes, I've requested.
Has she been unmuted?
Yes.
Okay. Ms. Tabawe, okay, unmute her. Her microphone is showing mute. Okay.
Okay. Good evening.
Okay. Good evening, Esther.
Yeah, good evening, everyone. My name is Esther Taboe, and I am a mother of 3 warriors, 2 boys, and a girl. I really want to appreciate Dr. Sota Omoigui for this life-changing discovery he brought to our doorstep, to our lives. It has really, really been wonderful. It has really, really changed a lot of things. My children, the first one, 5 years, the second, 3 years, and the third, a year plus now. Since August last year, when we started using the oxygen therapy, my God, we have not been to the hospital. My 3 warriors, they are so strong, energetic, full of life, no crisis, no pain, no hospitalization. Each time I notice they play rough, they are stressed maybe from school or they feel weak, I just place them on oxygen for 30 minutes, sometimes even 10, 15, 20 minutes. They are already responding positively. 30 minutes and everything changes and they are strong and healthy. When you see them and someone tell you they are sickle cell anemic, you will not believe because they are looking so good and it never changed their physical appearance. You cannot note, you can't even know they are sickle cell patients. I really appreciate Dr. Sota Omoigui for this discovery because he has changed my children's life positively with this home oxygen. And I really wish most of our health facilities in Nigeria will also key into this life-changing discovery because some hematologists around my area, even my children's hematologist, to be sincere, doesn't really believe in this oxygen therapy, but immediately I come in contact with this life-changing discovery and I key into it, it has been, it has made life so easy for me and my family. It has reduced our expenses health-wise, and I just wish the hospital systems here in Nigeria too can also go into this and continue to use it for us here in Nigeria so that we will no longer have a hospitalization for the sickle cell patients around us. At least for those that have been using it, because I also introduced it to a friend of mine who is sickle cell. She also shared her testimony. It has been life-changing since she started using it. There has been no hospitalization for her. Once she noticed she's stressed and all of that, she uses the oxygen and everything just go smoothly, living healthy life with it.
Very good. Thank you, Miss Esther, for your testimony. And I'm glad that this has made a difference to your life and the lives of your children. And this is the same report we get over and over again. People are welcome to go on the website, sicklecelldiscovery.com. Siwa, please post that on the chat and go and read the testimonials of patients who describe this as a miracle, amazing, life-changing. It's just incredible to see the kind of descriptions that they have been given there. Again, sicklecelldiscovery.com. Feel free to go there. And then Isiwa, I think, in fact, one of the amazing things here is that this platform has enabled me to see the devastation that sickle cell disease has done to people in Nigeria and all around the world. You know, severe complications that could have been prevented just by people reading the literature in the last 100 years. There's nothing new here. Scriver says crisis is reversible with reoxygenation in the first stage. He wrote that in 1930. We're in 2026, 96 years after. So anyway, I'm going to see. Dr. Ogbeye is here, Siwa. But before we call him, is there any other patient's testimony we can get here? So call the next patients and see who is here, please.
Noted. If we can have Miss Florence Obasola, if she's present.
Is she present here? If you're present, are you able to raise your hand up on the Zoom? I know sometimes it may be difficult for people to use Zoom and if they are not very familiar with it. But okay, if she's not, who is the next person you can call, Siwa?
Is Mrs. Hugo with us this afternoon?
I know she was here earlier. Mrs. Hugo, are you here? Okay, go to the next one.
Is Mr. Sylvester Tamba with us?
Yeah, he should be here. Maybe he may come in again. If I see him, I'll let you know. So let's go to the next. That's going to be Dr. Ogbeye. Dr. Ogbeye is an orthopedic surgeon, and he deals with a lot of the complications of sickle cell disease, especially a vascular necrosis. So I'm going to, Siwa, can you unmute Professor Dr. Ogbeye here?
Yes, the doctor is unmuted.
Okay, Dr. Ogbeye, welcome to the second anniversary of my discovery. Thank you very much. I know you've been an advocate of my golden hour discovery to your patients. So please let us, feel free to, let me see if he's able to share his screen. Let me see, because he needs to be able to share his screen. Dr. Gbe, are you able to share your screen or do I need to?
I'm trying to do that.
Okay, if you can't do that, I can make you a co-host so you can share your screen. Hold on. Let me see. Let me see if I can make you a co-host. Hold on. Otherwise, I have to change the permissions.
Can you see my screen? Can you see it?
Let's see. Hold on. I can't see your screen yet. So hold on. Let me see if I can do some permissions here so that.
Can you see it now?
Not yet. Hold on. Let me see. Let me see. Yeah, you should be able to share your screen.
My presentation is on. It's a power slideshow.
Okay, some people say they can see your screen.
Okay.
Yeah, it's okay.
Can I go ahead?
Please go ahead.
All right. Congratulations, Dr. Sota, on the second anniversary of your discovery. I have been an advocate. In fact, I've been talking a lot to most of the patients I meet with sickle cell disease. I always introduce them to the Discovery website, and I'm sure you have come across a few of the comments from them. My little talk today my talk today really is about the orthopedic complications of sickle cell disease. It's inevitable that once you pass the golden hour and there's crisis, sometimes you find that complications may occur as a result of the fact that there's ischemia to the tissue. So I'm not going to go into the details of the abnormality, but it is clear that 50% of African tribes suffer from sickle cell disease. It's an abnormality in the hemoglobin V chain. And the other 8% of African Americans also suffer this disease. And we have the affectation of those in the Mediterranean from Arab states. The underlying pathology really at the end of the day is that there's a resultant anemia as a result of vaso-occlusive crisis. And when the tissue, there's a lot of ischemia in the tissue, then you find that you may have some immune status decrease, and then the patients are prone to infection. And so most of the complications really are based on the fact that you have vaso-occlusive crisis that leads to some ischemia. There's a way blocking my view. The musculoskeletal complications occur in about 57% of the cases. And to just make it simple, there are the blood vessels, the blood flow to the tissues are blocked because of the hemolysis. There's tissue starvation, and the body or the musculoskeletal, the bones will always have to react. And what you find is you have bone marrow hyperplasia. So there's overproduction of blood cells in order to meet the demands of the body in the midst of that starvation. And this results in acute crisis and chronic joint and bone damage as a result of the fact that there is ischemia. Because of this chronic anemia, what happens to the bone? You find there's resultant expansion of the medullary spaces of the bone marrow. There's thinning of the cortices of the bone itself. And then there's reversion of the yellow marrow to red marrow. And then in order to meet the oxygen, to meet up the oxygen demand, you find that red blood cell producing tissues that are made available in the body just as a defense. They call it the extra medullary, that is outside the bone, where the tissues that are trying to form blood to meet up the oxygen demand. However, in the bone, there's ischemia and an infarction, and this leads to disturbance of growth of the individual. And where there's infarction and reduced immunity, you find that organisms are able to thrive. There's a phase of, where organisms invade the tissue through the bloodstream. And since there's no defense, the organisms multiply. And at the end of the day, you find a situation where there's affectation of the muscles and soft tissues. In the bone itself, what happens is you will find what they call infection of the bone, called osteomyelitis, which initially is chronic because it's an acute inflammatory process in which you have a sedation formed. When there's no decompression of the bone as from in the hospital, then it becomes a chronic situation where the bone dies and you have what you call the bone-in-bone appearance on X-ray. And that is the chronic stage of osteomyelitis, in which you find that there is dead bone within a new bone that is formed. Because this bone is weak, what happens is that with mobility or use of that affected part, the bone can break, and we call that a pathological fracture. Sometimes you find that the affected bone, the extremity, have the adjacent joints. This infection may trigger to the joints, and then you have collection of pus in the joint, and we call that septic arthritis. And these things are very common in children, and so you may have to drain pus from the joint sometimes. So this is a picture of a typical sickle cell disease patient. They see what I was talking about. The marrow becomes, this is actually still even a situation where you still have some cortices that you can see, but I have some more other pictures. But you can see here that the head of the femur that is usually secular is damaged. And so it's no longer secular, and the joint itself has become, you can't even differentiate. There's fusion of that joint. And so patients will have pain and difficulty in walking. And I can go back and say that you find that the bone is like a slate, it's whitish on X-ray. So this is an evidence of myohyperplasia and the fact and effect of ischemia. So I mentioned earlier on that because of the increased sickling and vaso-occlusion, in which the vessels are occluded, patients come in with pain, which we call the vaso-occlusive pain crisis. It is a very, very pathetic situation when you see patients present in the hospital. They present with bone pain, joint pain, swelling, and sometimes you have this swelling affecting the hand and the foot, especially in children, you're very young children. And in such situations, sometimes you never know they have sickle cell disease. You have what we call a hand and foot disease. They call it dactylitis. Sometimes you find chronic ulcers in the ankle area, especially around the malleoli. And these may be multiple sometimes in nature. And you may have stunted growth. Patients are not thriving like their counterparts or their peers. You have skin changes around the skin, especially around the ulcer. There's hyperpigmentation, dark skin. And in some cases, because I've seen a lot where the patients, because of the pain, they've started abusing drugs. They go to the local drugstore and buy opioids and they start injecting themselves. So you have a lot of thrombosed vessels in the extremities. And some of these thrombosed vessels becomes ulcerated. And you'll be surprised that they are experts at injecting themselves, some of the patients. I've had a situation where a patient had to deceive the governor of Edo State at a point, well, he's late now, but he was injecting himself and almost all his veins were thrombosed. And then you have psychiatric manifestations as a result of pain or as a result of complications or use of abuse of drugs. So, and for you to treat such patients, you make sure that you have psychiatric evaluation and for them to be distanced away from the drug abuse itself. So the complications could be acute or chronic. So the acute complications will include bone marrow infarction, which is what I've mentioned earlier on. You can have acute osteomyelitis, in which if you decompress immediately, you can get pus and that will not progress. However, you find situations patients are presenting late and it can be in multiple bones in the body. So you find that they can progress to chronic state in which you have dead bone within a new bone formation. In septic arthritis, I mentioned pus in the joint, and you have to do arthrotomy, or we call it knee wash or hip washout, or sometimes it's the shoulder. And you also have some cellulitis or myonecrosis when it becomes progressive, and you have bleeding into the joints or into the soft tissues of the extremities. These are acute complications that are commonly seen in patients with sickle cell disease. The chronic complications that are commonly seen that are of very important to most families is the situation, because this occurs very early. You see a 6-year, a 10-year-old having what you call avascular necrosis. I've seen that it's more commonly around the hip, the shoulder, and the knee. The knee is the least commonly affected. But patients with sickle cell, that's SC, are the ones you commonly see with shoulder affectation in which the head of the humerus has collapsed. But the commonest you find is avascular necrosis of the hip joint. And in that situation, those are the patients you might subject to surgery, especially when the pain becomes unbearable and is disturbing activities of daily living. Such are the patients you might need to do total hip replacement for. And the youngest I have done the hip replacement for in Nigeria is a 14-year-old from the Delta State, because the joint was very bad. But most times you find that you may have to temporize and manage pain hydrate properly, do physiotherapy until they are mature enough to have a joint replacement. Chronic osteomyelitis of the extremities, one of the common ones also, complications you may see. What has happened in this situation is persistent ischemia, infection within the bone, and as a result of the persistent infection, the bone dies, but there's new bone formation. So it's like a dead bone buried in a new bone being found. As it's called the sequestrum. So that's what you do, a sequestrectomy to remove the sequestrum. At times you have what are called osteoporosis or osteopenia, where the bone is very thin and the patients fall and they break their bones because the bone is very thin and osteoporotic. We have to call it pathological fractures. Patients with sickle cell disease also develop spinal deformities in which you have vertebral collapse, and you find that they find a situation where they're walking in a bent situation called scoliosis, or sometimes they have kyphosis, in which the deformity is protruding like a patient who's had, because of the vertebral collapse, the patient is deformed while walking. Stunted growth and all that are very commonly seen. And chronic ulcer. The ulcers can be very, very painful. And, they have neuropathic pain. So those are the pain patients, that you really, really, have to admit for elevation. And sometimes you may need to call in a plastic surgeon to help you do some skin grafting. But before they do the oxygenation is very, very important. Sometimes you may have to put them in oxygen tent. And that helps to heal the very stubborn ulcer. So a combination of use of oxygen, hydration, antibiotics, and skin grafting. With all these complications, we're told to do some plain X-ray, CT scan, MRI. These are all added to this talk so that patients who are listening at least are aware of some of the investigations you will be asked to do. By and large, they help as supporting, way in terms of reaching adequate diagnosis in the treatment of the complications. I'm trying to make it fast so that we can save some time. So with vaso-occlusive crisis, in the hospital, hydration and pain control is very important, and opioids. Use of opioids, yes, but there are some opioids that are not particularly very good for sickle cell patients. The use of maybe something like tramadol, I don't think it's particularly very good. Or you may have to use morphine. And so it's very important that the pain, the analgesia, or physicians that are very good in pain control are invited in the management of when patients are admitted. Sometimes you may have the use of hydroxyurea, or sometimes patients are transfused. And with infection, we need to use antibiotics. I've talked about the ulcers, so I won't dwell into that anymore. Acute osteomyelitis, the organism that causes osteomyelitis in most of the patients, the common organism is still Staphylococcus aureus. However, you have instances where Salmonella has been implicated in the cause of ulcers in the sickle cell patient. So if you have an ulcer that is growing Salmonella, most likely the patient may have sickle cell disease. However, the commonest organism is still Staphylococcus aureus. So most of the time, the joints are warm and swollen and very tender, and then there's no movement. So it is important that surgical decompression and supportive care is given. I've talked about avascular necrosis, where you have to do joint replacement, and this is a typical joint. You'll see the damage has been done, see the marrow aplasia, and then there's thinning of the cortices. You can see that here. And then you may need to do a total hip replacement. You'll be surprised this can be done in a very young person, obviously, which means that as they grow older, you might have to revise. So by and large, that is just a short talk on the complications of sickle cell disease. There's more to it, just that I have to give a summary. The complications are very disturbing, can be depressing, difficult to manage by the physicians, and can be costly to parents or those who are affected. Timely prevention of vaso-occlusive crisis is very important because if that is prevented, which is the basis of most of the complications, then you find that you may not have those complications. So I go with Dr. Sota Omoigui to say that home oxygen helps, and the timing is very, very important. If every one of the patients can have home oxygen therapy, I believe so, that vaso-occlusive crisis will be prevented, and those complications that are supposed to be costly and difficult to manage will not be seen. Thank you for inviting me and giving me the opportunity to speak.
Thank you, Dr. Okweye.
Yes.
And Dr. Okweye is a world-renowned surgeon who's specializing in arthroplasty. And I had an insight, Dr. Okweye, in that when someone like you takes all the effort, does the surgery, or there's a skin graft on a leg ulcer,
Yes.
and before my discovery, the patient still ends up with the wound breaking down or the ulcer breaking down because the same factors of ischemia, of poor
Exactly.
perfusion are still there after the surgery.
Yes.
Because I know some of our patients on the platform say, oh, I went to this hospital, they didn't do a good job. But at the time you did the surgery, my discovery was not yet out. You didn't have home oxygen. So
No.
you have the surgery, you're going to sleep, you're having what we call nocturnal hypoxemia, which means a low oxygen environment, which often occurs in sleep. So you are having the same sickling in the bones, in the skin, everywhere that caused the problem in the first place. So Dr. Bayer, I'm very sure that as you encourage your patients to get home oxygen, you will see that your surgical work will even do much better.
Yeah, no, especially this the fact that it's affecting very young patients. 80% of total hip replacement done in Nigeria today are as a result of sickle cell disease. I tell you, 80%. And so
That is,
published 2 years ago, in which 80%.
that's a lot of damage. That's a
Yes.
lot of, and Dr. Bayer, later in my slideshow, I'm going to go into the economic damage of sickle cell. What's that? My home discovery will raise the GDP of Nigeria by preventing all these complications, hospitalizations, blood transfusions, organ damage that are going on. Sickle cell, the mortality of sickle cell in a study by Lance Cron in 2013 has increased over the last 20 years from 2005 to 2019. The mortality, even those on hydroxyurea had almost the same mortality before and after the hydroxyurea because no drug can stop, reverse, prevent a sickle cell crisis more than a gas. And you will see my study, all the drugs that the pharmaceutical companies have tried to produce or try to provide molecular oxygen. Like hydroxyurea, it increases hemoglobin F, which has an increased oxygen affinity because for the fetus in the uterus is a hypoxic environment. So hemoglobin F evolved to allow the fetus to extract more oxygen. Is everything with sickle cell deals with oxygen. Oxygen, oxygen, oxygen. And the point is that no tablet, no medication, no drug that has to go through the GI system can produce enough oxygen to prevent, reverse, or stop a sickle cell crisis other than the main actor itself, oxygen. That's the ultimate actor. So thank you very much, Dr. Bayer. And yes, I've seen some of your patients who've come from multiple places. But thank you for being part of this discovery. So is you the moderator? You're going to be calling Dr. Onogo next?
Yes, Dr. Onogu is our next speaker. He's been asked to unmute.
Thank you, Doctor. Thank you, Dr. Baye. Welcome,
Thank
Dr.
you.
Onogo.
You cannot with me, yes.
Yeah, I know Dr. Nogu, I know friend.
Oh, you do?
Mr.
Small
Fred,
world.
I was going to say so because we are together in my Sinai hospital.
Yes,
And he
yes.
went there for his postgraduate, for the orthopedic training in Togobi. And we were all together in First of Benin. It was a year of
Yes.
it was a year ahead of
Wow.
I am so excited meeting you here.
Yes,
Okay?
thank you.
It's my pleasure. And I want to just say once again, I want to use the opportunity to celebrate Dr. Sota Omoigui for this wonderful discovery. And I tell you, I want to speak from the position of empathy, with this. If you've really interacted with these patients over the years, worked with the parents, worked and you met the parents severally, you understand some of the challenges, the emotional torture these parents go through. The patients, they only believe that they have children that will never live long. It's like a death sentence on their children. It's a matter of time that some of them, sometimes they have been told they will not even celebrate their 50th birthday. Some of them will not go beyond teenage and so on and so forth. And sometimes they go through some negative emotions, very worried, very depressed, and it has resulted to a lot of marital problems, emotional challenges. I'm talking about when you interact with these parents. And sometimes these feelings are rubbed upon rubbed on these children, on these warriors. And these warriors also get anxious. And over time, you find that one of the triggers, one of the non-tangible triggers to their crisis is emotional. Negative emotions, anxiety, fear, depression, sadness, unhappiness. In these patients, and most of the time when they go through this, because in the family, there's family tension, there's no moment of joy. Parents cannot look at their children and feel happy. Every now and then they are being rushed to the hospital, they're spending money and so on and so forth. And I came across Dr. Sota's, I read, the website and I went, and I tell you, it's been a wonderful experience with these parents. It's no longer a death sentence on their children. For the first time, some of them cannot laugh when they call me. It has reduced, their expenses, the frequency of hospital visitation. And so, and one thing I want to mention here, is that the main significance in this discovery is that it tries to kind of deal with the main process, the main trigger, the beginning of the whole problems of sickle cell patient. It prevents this. The main problem is sickling process. The sickling of the red blood cells of these sickle patients is the beginning of the whole challenges. Just like Dr. Boye has noted, it's just from that particular process that when that happens, there's polymerization of the hemoglobin, they clump together, they're sickling, they block the blood vessels, and this can happen several times in a day, several times in a week. And, several cases, several times, the organs are ischemic. Eventually, some of them will become infected. And of course, there'll be multi-organ dysfunction over time. All right. But imagine a situation where you have that particular beginning of this crisis. You can deal with it. All these challenges that we have just mentioned would be prevented by simply just giving the oxygen at that particular time to prevent the sickling process, which is the main trigger, which triggers all the cascade of all reactions that will lead to the vaso-occlusive crisis, that will lead to the massive red blood destruction leading to blood transfusion, that will lead to all the stroke, the ulcers, everything you talk about, the acute chest syndrome, is just from that process. And this singular discovery has prevented all this, had reduced the frequency in all these patients, including all the things, all the orthopedic complications, and Dr. Boye had just mentioned on this single process. And I found out that over the time, when these things are used, I've been using oxygen in my practice to manage their cases, but I've never had this result. We just use them, but I've come to realize that what you do, even when you do, can only prevent further sickling, but can never deal with already irreversibly or irreversible sickle cell already, which already triggered off the cascade of reactions that the body will take care of. They do over time, 2 days, 3 days. But this aspect, with oxygen, even in admission, it can only prevent further sickling process, which I also advocate for patients that even when they come in, for whatever reason, still put them on oxygen. It will prevent further sickling while the body takes care of, the already irreversibly sickled cells, either through sequestration, phagocytosis, and so on and so forth. Whatever the body takes care of it. Now, what I want to say here, very, very important is that, like my documentary has just simplified everything, is that this is, it works. It's a result of scientific research work, which is evidence-based and therapeutic. And I'm talking to my colleagues who are on this platform. They should just give it a chance. I've made a lot of efforts to connect to the Association of Private Medical Practitioners of Nigeria, the president, national president. I have not succeeded. For whatever reason, they have never given me, giving us opportunity for Dr. Sota to address them. Like Prof was talking about all those other trials that were it's not, they are not, I don't think those trials are very necessary because oxygen has been tried over time to be safe. And we have been using it for other reasons, COPD and so on and so forth. And it's been working, without, toxicity. So it's not like we are discovering a new thing. Oxygen is not just being discovered. It's been tried over time. So it's no longer what has to be done. All we are talking about, use it at a pilot. It's a time-targeted discovery. And I want to encourage everyone to use it, even for the warriors who are listening. Some of you who are here, some of you are still believing in what some of your physicians are telling you. But I know they get to know the truth very soon. That it doesn't work. Please avail yourself with this particular which one you can afford, whether the cylinder or the machine, whatever, which one you can afford. Please avail it in your own interest. And you find that these children, you will live longer than you expect. And one thing I've experienced again is that most of these patients, when you start with some of them who are very young, they benefit more. And when you start using this thing before they start developing complications, they will never develop any complication. If this oxygen started early in them, they may never come down with any of these complications, whether VN or the crisis of the hip or whatever. They will never come down with it. But for some of them who are already on that, who already come down with this complication, it will only minimize the pains they go through, okay, and make them improve the quality of life in them. So for all of you who have children who are warriors, who are very young, who are not come down with any of the complications, in your own interest, just after this seminar, go wherever you can access the oxygen and start using for them. All these complications, these patients, your warriors will never go through any of these complications. And once again, I want to just thank Dr. Sota, and I want to celebrate him. I understand that today is also his birthday, and it's my wish for him that that the Lord will just go with give him long life, to be able to benefit from some of these discoveries, some of the work he has done. People have been praying for you, and in diverse ways, and I know God will answer them. Will say yes to all their prayers. Once again, I say congratulations, happy birthday, and also happy second anniversary of your discovery. Thank you very much.
Okay, thank you very much, Dr. Onogo. And so now, Isiwa, what was the next item on the agenda?
We have another doctor scheduled to speak, Dr. Ngozi Onia of A1 Memorial Hospital.
She had to leave. I think she was here long enough. So what was the next? I know there was one of the patients showed up, one of the patient's fathers, but he has disappeared again. So what was the next item, Isiwa? Is it my slideshow?
Next is the annual State of the Discovery address.
Okay, thank you, Emia. Let me pull up my slides and then I'll share my screen. So hold on, please. Okay, so hold on. Okay. So let me pull this up. Okay. Can you see my slide? All right, I can't hear you guys. But anyway, I'm going to start my presentation. State of the Discovery, second year anniversary. Today's date, July 4, 2026. And the whole essence of the discovery is the right treatment, inhalational oxygen, in the right place, at home, at the right time, the golden half hour. This is the first solution since the recorded history of sickle cell 7,300 years ago to prevent, reverse, and stop a sickle cell crisis. The sun has finally risen after 7,300 years of darkness. People have struggled since 3,200 years before Christ to find a solution, and they were never able to. Not even the drug companies, not even the medical researchers, none of them could do that because they were all looking for a medication, even though the solution was right there in front of them, hidden in the literature, in plain sight. In these 2 years of the discovery, we have more than 2,000 members on 3 discovery platforms, and more than 72,000 views on TikTok. And a preliminary study showed a reduction in blood transfusions and hospitalizations of about 80%. And I believe it can get to 90 to 95% without malaria and typhoid. Sickle cell disease essentially is a low oxygen disease. That's all what it is. The sickle hemoglobin has a low tolerance to hypoxia, which is a low oxygen environment. So when there's a low oxygen environment, it undergoes polymerization, which means it changes shape, becomes sticky, adheres to the blood vessel wall, and obstructs the blood vessel. What has been missed with all these scientists, hematologists, researchers, is that the initial phase of a sickle cell crisis is reversible. It's been in the literature since 1930. There's nothing new here. And it is initially reversible with reoxygenation. That's what is in the literature. So you give oxygen when it's reversible, the cells go back to normal. Just as simple. However, once they get past through that reversible stage and they keep on sickling, the cell membrane gets damaged and the cells become irreversibly sickled. At that point, the cell is dead. Oxygen can no longer recover it. It's like giving CPR. When somebody is sick or dying, oxygen will help him recover. If the person is dead, you can put all the oxygen you want. It's not going to wake him up. The same with the red blood cells. Home oxygen interrupts this cascade of hypoxia when reversible sickling begins before it gets to vessel obstruction and pain and organ damage. And that's the key, preventing the progression from reversible to irreversible crisis. And before my discovery, there were a lot of myths. Even the vice president of Novartis, a big pharma company in the US, was reported telling Fierce Pharma, a publication in 2019, that, medical science have not been able to solve a vaso-occlusive crisis that is so unpredictable and so severe. It's not unpredictable. Low oxygen during sleep and stress are major identifiable triggers. So when somebody, a family, a child, feel they have no control, no knowledge, no power, and they go to bed and wake up in a crisis, they are afraid to sleep because they don't know if they're going to wake up in a crisis. And that creates a lot of anxiety for the child, the family, because they don't know when the crisis is coming. But that's not true. It's a low oxygen environment, and the greatest risk of a crisis is during sleep. So the myth, patients are helpless bystanders. Once a crisis starts, then it's a one-way trip to the hospital. No, my discovery has come to change that. Patients can take control using home oxygen in the golden half hour. It's as simple as that. And then the myth, a crisis and inevitable path to hospitalization. No. Sickle cell crisis cannot be reversed. No, again. Reversible sickle cells can be restored to normal with home oxygen in the golden half hour. Another myth, blood transfusions are inevitable. No, if you stop the vaso-occlusive crisis in the golden half hour, you reduce or prevent blood transfusions. We have patients on the platform who've not had crisis for more than 1 year. During my time in the FDA, I never saw any drug that had such a significant impact. None. We were happy to approve drugs with 20% impact, 20%. Myth, hydroxyurea is the only available standard of care. No, hydroxyurea does not even reduce crisis more than 50%. Mortality rate in adults, even with and without hydroxyurea, have been the same. Home oxygen directly reverses sickling. Home oxygen is the gold standard. And that's based on the existing literature. Anybody still asking for studies, you go and read the studies that have already been done instead of asking for more studies. Studies have been done, clinical trials have been done, but nobody was reading them. Nobody was connecting the dots for more than 100 years. Myth. Again, reversible cells, once sickled, are damaged for good. No. And Melanie Gonick in MIT had a video, it's on YouTube, it's called Reversible Sickle Cells, and showing in their controlled lab settings how reversible sickle cells, when reoxygenated, go back to normal. Another myth, air travel is safe without oxygen. And this is where the greatest disaster has come from. Even the NIH, at the highest levels of medical establishment of healthcare policy in the United States, advises patients with sickle cell to dress warmly and drink lots of fluid. That's utter garbage. They should know better, because at those high altitudes, partial pressure of oxygen is low. And hypoxia is one of the triggers of sickle cell crisis. So you can see why people have been damaged, injured, and killed over the last 100 years with this kind of advice from the highest medical establishment. Supplemental oxygen is required for any flight exceeding 30 minutes. Oxygen saturations are measured as low as 77% versus the normal 95 to 100%. This saturation occurs within 10 minutes of takeoff. What are the complications? Bone pain, splenic infarct, avascular necrosis, prolonged crisis, some cases death. Even in the last few years, several of our best and brightest have died after taking prolonged flights, including physicians. Some of them may have heard of my discovery but didn't believe, and that's unfortunate. But supplemental oxygen is required for any flight exceeding 30 minutes. Now, let me go through the studies. This has been a century of discovery. From 1910, when Herrick first described sickle cell disease, 1930s, Scriver and Well in Canada showed sickling varies with oxygen pressure and is reversible. 1930. By the way, 1927, Hahn and Gillespie suggest that hypoxia, low oxygen environment, causes sickling. Meanwhile, in 1921, Banting and Best isolated insulin for diabetic patients. And since then, diabetes, the lifespan of patients with diabetes is now up to 68 years old. But even though we knew this from 1927 and 1930, the lifespan of a male adult is 38 years old for sickle cell and 42 years old for a female patient, because nobody was reading the literature, nobody was putting the dots together when all these researchers had done the studies. Okay, now let's go to 1983. Frank and Chu showed reversible sickle cells regain discoid shape upon reoxygenation. 1991, Hebel shows deoxygenation-driven membrane changes are reversible with reoxygenation. 2015, MIT, Melanigonic, shows visually how reversible sickle cells respond to reoxygenation. And 2024, I made my announcement of my discovery of the golden half hour. So this is the pathway leading up to my discovery. So again, reversible sickle cells revert to their original shape upon reoxygenation. This is the window for home oxygen to work. There's nothing new about home oxygen. It's used for COPD, for asthma, for everything. There's nothing new about it. Doesn't need any clinical trial for home oxygen. The same oxygen, the same nasal cannula, 2 liters per minute that's used in the hospital when it doesn't work because the crisis is already irreversible by the time the patients get to the hospital. That this irreversibly sickled cells, repeated sickling damages the cell membranes. The cells can no longer return to normal. The cells die, obstruct the blood vessels, lead to severe pain, lead to organ damage. And the body has to clear these cells by destroying them because there's no way we can remove them from obstruction. And what does that lead to? Severe anemia. Then you start the cascade of blood transfusion, acute cases, all kinds of complications, avascular necrosis, leg ulcers, just from the fact that they are irreversibly sickled cells. So why did we miss this for 100 years? Because by the time the patients got to hospital, sickling was already irreversible, beyond the reach of oxygen therapy. My discovery of the golden half hour is a time-dependent intervention, just like the golden hour for stroke or the critical window for a heart attack, where timely action determines outcome. So we have to change the paradigm. That's what my discovery is about, changing the paradigm from a reactive approach, treating patients in a hospital only after irreversible crisis, severe pain, organ damage. So the whole house is burning down by the time you're calling the fire service. To preventing a preventive, proactive approach. Home oxygen restores reversible sickle cells and stops a crisis in the golden half hour. And for those who want to study home oxygen, it's available. Order oxygen from your medical supply store, get some of your patients, write your protocol, and do whatever studies you need to do. I provide the knowledge. It's on the website, sicklecelldiscovery.com. So take the initiative and go and do your studies. And that's fine. But don't ask for studies and you're giving a donation of oxygen and you're not interested. Now, what happens when we wait? When we wait for an irreversible crisis, severe pain and suffering, acute chest syndrome, avascular necrosis, stroke and brain damage, priapism, kidney damage requiring dialysis, organ damage, and death. Now, look at this. Look at priapism, which is prolonged erection of the penis. Normally, that will lead to surgery. But we have patients who put on home oxygen and priapism is reversed within 10 minutes. Within 10 minutes, with home oxygen in the golden half hour, we already have several patients who've been able to control their priapism like this instead of ending up in the emergency room and having surgery. So the prevention is this: for any stressor, physical, intellectual, environmental, or physiological, inhale oxygen for 10 minutes to 2 hours before sleep or use it through the night. Sleep is the most dangerous time for a crisis. And what is the flow rate? Children, 0.5 to 1.5 liters per minute. Adult, 1 to 2 liters per minute. And you must use a continuous flow concentrator. Those are the approved and authorized concentrators. Pause, those concentrators will not work. So buying all those cheap concentrators on the internet, you're just wasting your money. On the website, sicklecell.discovery.com, we have a list of authorized concentrators. We have distributors in Nigeria. Some of those concentrators can be shipped to you from the United States, so wherever you are in the world. Now, if you use home oxygen in the golden half hour and your symptoms don't stop, please proceed to the hospital because something else is going on, either an infection or malaria or hemolysis that's going on. Our study showed in 98 patients, 2025 study, 80 to 90% crisis prevented or aborted. We have patients who've not had a crisis in 1 year. We have fathers who say for the first time in 12 years, they were able to save money because they were not spending all their money on hospital bills. We have children able to go to school, able to finish their exams for the first time in years. 80% reduction in blood transfusion, 79% reduction in hospitalization. And we are sure the more studies, we welcome them. You're going to see an even bigger effect than this. Meanwhile, patients who do not have oxygen continue to suffer high crisis burden, mostly with greater than 3 crises per year, confirming that the treatment effect is real, not regression or bias. Patients report improved sleep, emotional outlook, social participation, and reduced fear of hospitalization. Here, let's listen to some of the voices from the movement. These are all on the website, sicklecell.discovery.com. It's from one father. Since then, he hasn't been hospitalized at all. The longest time we've gone without hospitalization since home oxygen. Another father says, for the first time in 12 years, I truly saved money this year. No frequent hospitalization. Here, another father says, our boy has not had any crisis since August. No hospitalization. God bless this discovery. The discovery again is using oxygen at the right time in the right place instead of waiting to use it in a hospital. Hold on. Let me go back to my slide. I'm going to resume the slideshow. I'll soon be done. So hold on. Okay, so the pharmaceutical drug companies, they've done their best, but their trials have failed because they couldn't stop a crisis. Adagvio, phase 3 stand trial failed to reduce painful crisis. European Union authorization was revoked. Inclacumab, just the most recent, August 2025, did not meet its primary endpoint for reducing vaso-occlusive crisis. They've tried, but they cannot, nothing can reduce a crisis other than home oxygen. Nothing. Now, we have some new drugs in the pipeline. They are what we call pyruvate kinase activators. So what they do is they decrease a chemical called 2,3-DPG and increase ATP. So, which enables the red blood cells not to offload oxygen and keep oxygen more so they don't have to sickle. The most promising is etavopivat. Hopefully, it's going to be approved later this year. But only 27% reduction in the crisis. Now, 48% had an increased hemoglobin, and it had some side effects. Some patients still had crisis, headaches, fatigue, GI symptoms. So that's the most promising. The other one in the same class of drugs, mitapivat, they show a hemoglobin response, which means they reduce the chronic hemolysis. But this one failed its primary endpoint. It couldn't reduce vaso-occlusive crisis. That's the mitapivat. Hydroxyurea, the stable, it was originally developed for cancer. They noticed that, I believe it was in a baboon, that it was raising a level of hemoglobin F, the fetal hemoglobin. So they tried it on human beings, and it was reducing the frequency of painful episodes, but unlike home oxygen, does not directly reverse a sickle cell crisis. It reduces painful episodes by about 50%. Now, side effects can be quite serious. Neutropenia, suppression of the bone marrow, elevation of liver enzymes, infertility. So I recommend the low-dose hydroxyurea, which is a maximum of 500 milligrams per day. There was a study that came out of, I believe, Ibadan, where they found out that the low dose is just as effective as any higher dose without all the serious side effects. Now, of course, we have the cures: bone marrow transplant, leukemia, Casgevy, gene therapy. But these ones cost 2.1 to 3.2 million for the gene therapy. Bone marrow transplant in Nigeria, they are charging 40 to 60 million naira. Well, again, that's fine if you can afford it, but I need to say this here. Even if you're going for a bone marrow transplant or gene therapy, you still need your home oxygen, because any organ damage you have, the organ transplant will not repair that. It will not reverse that damage. It will not restore that damage. It will remain with you. But there was a patient who had sickle cell, had bone marrow transplant way before my discovery. She's cured of sickle cell, but she's bedridden because all the crises had damaged and destroyed her lungs. So she's essentially on oxygen 100% of the time, not just during sleep, 24/7. But she's cured. She doesn't have sickle cell anymore. So you still need home oxygen to prevent your bone damage. So hold on. I hope my slide is still on. Okay, so So I will soon be done. Oxygen is the cheapest treatment for a chronic illness. An oxygen cylinder costs $130, or about 190,000 for a cylinder, 15,000 naira for a refill. Concentrator is about $500 or 750,000 naira. And but I know many of our people still can't afford even the oxygen cylinder or to refill it. So now let's look at this. Your home oxygen equipment, an oxygen cylinder or a concentrator. Continuous flow, concentrator has to be able to give up to 2 liters per minute. And the oxygen purity is the most important. At least 90% oxygen purity across all flow rates. For Nigeria, with a rechargeable battery, which is important where power is erratic. Now, there have been studies of long-term of use of oxygen. Legono et al., 2021. So those who are asking for studies should go and read the literature. The studies have already been done. She did a 5-year study of home oxygen therapy and found out that it was safe with no side effects for children with sickle cell disease. It's been done. Read the studies. So oxygen is available worldwide. Wherever you are, there'll be a medical supplier that can supply you with an oxygen cylinder or oxygen concentrator. And for those who need, we can also ship a concentrator to you from the United States. So anywhere you are in the world, just go on sicklecelldiscovery.com. In 1921, Banting and Best discovered insulin for diabetes. And the whole lifestyle of diabetes changed. It became a manageable disease. Now people say, oh, they are looking for a cure. Most of our diseases are not cured. They are managed. High blood pressure is not cured. Diabetes is not cured. Thyroid problem, these are all managed. Sickle cell disease, with my discovery of home oxygen, is now a manageable illness. Is no longer a sentence to pain, suffering, organ damage anymore, anywhere in the world. What is the economic impact of sickle cell? Estimated impact in Nigeria is $4.8 to $7.2 billion, or 7.4 to 11.2 trillion naira, lost annually every year through hospital admissions, emergency department visits, blood transfusions, organ complications, premature mortality, lost school attendance, lost workforce productivity, caregiver time. What was the potential impact of my discovery? In Nigeria, based on potential annual reduction in sickle cell burden, just from the study of 98 patients we did, my discovery can increase the economy of Nigeria by $2.5 to $4.5 billion per year, or 3.88 to 6.98 trillion naira per year. And in Africa, that's $4 to $7 billion, or 6.2 to 10.85 trillion naira a year. And in the United States, $1.5 to $3 billion a year. That's the potential impact of my discovery. I must remind people, for oxygen safety, keep your oxygen equipment at least 6 to 10 feet away from open flames, heat sources, or electrical appliances. Place equipment in a well-ventilated area. If you're using portable concentrators, ensure your batteries are charged. Maintain a backup. Regular checks, inspect your oxygen equipment for leaks or malfunctions. Replace or repair faulty components promptly. Storage, store your oxygen cylinders upright, secure them to prevent tipping. Fire safety, no smoking anywhere near oxygen equipment. Avoid using flammable products like petroleum-based ointments or alcohol near oxygen. Backup plan, have an alternative oxygen supply in case of equipment failure. So even if you have a concentrator, if you can afford it, also get a cylinder as a backup. If you have a cylinder, if you can afford it, get another cylinder as a backup. So in conclusion, after 7,300 years of human history, from the pre-dynastic age in Egypt, more than 3,200 years before Christ, the first solution to prevent, reverse, and stop a sickle cell crisis has been discovered. Lives have been changed and saved for hundreds of families all over the world. The state of the discovery is strong. God bless Nigeria, and God bless the United States of America. Thank you. Okay, that's the end of my State of the Discovery address. So, Siwa, let's see if let's see. I know this has been a very long presentation. Few people have left, but let's see who's still here. Let's see. Okay, so Siwa, what's the next item on the agenda? Do you need to, is it the Dr. Sota concentrator? Is that what we need to show?
Next, we do have a showing of the concentrator, so yeah.
Okay, so hold on, please. I will have to share my screen. Let me pull up the Dr. Sota concentrator. Hold on. Okay, let me come and share my screen. Okay. J2 Sota, specifically manufactured for Nigeria. I'm going to turn it on here at the back. The power switch is at the back. You can see here, oxygen purity is 93%. Flow rate is at 1 liter per minute. And here I'm going to increase the flow rate to 2 liters. And you can see that it's still maintaining 93%. And then if you see over here, this is the battery charger on the battery. So it operates, we can operate with battery. Battery is independent, it's not inside, so it just has to be connected to the machine. And that's the user manual and the cannula over there. And here we have the bag over here, a storage bag, and right next to it is the trolley. So this is the long pin J2 Sota with a backup battery for Nigeria. And then here, this is the concentrator for the US, Europe, UK. This is the King, and it has no battery, so it's used for places where they don't have any power supply issues. So this is the Zik King here, and then you're going to see, let me turn it on. So that is the thing. Is where the cannula stays. Okay, we use it up to 2 liters, and it maintains the oxygen purity. And then right over here, both of these other concentrators are for home use only. Right over here is the OxLife Liberty 2, and this is FAA approved. It can be used in the aircraft. Actually, this most portable continuous flow concentrator that can be used for aircraft. See, if you turn it on here, you see the OxLife Liberty 2 right there. So this is very portable, can be used in the aircraft, can be taken to school. Actually, all of them are portable. Just that this is the one that can be used in the aircraft. And so that ends this demonstration of oxygen concentrators for Nigeria and all the countries in the world. Thank you very much. Okay, I'm back. So I hope you guys saw the concentrators. Were able to see the video? Sure, were you able to see the video?
Yes, we did.
Okay, great. Okay, so we're almost getting, thank you for your feedback. We're almost getting to the end. Sure, what's the next item on the agenda?
An update on the sickle cell handbook and medical protocol.
Okay, yeah, so please put a link in the chat platform. The sickle cell handbook and medical protocol was done to guide physicians, patients, and doctors based on my discovery of preventing, reversing, and stopping a sickle cell crisis, as well as management of the crisis in the hospital. So I think we have a link. Is you or Helen? Can you put that link in the chat for people who want to go and see that? And the sickle cell handbook is free for people to use. Print it out, distribute it. I said no copyright. It's done free of charge. Feel free to use it anywhere you like. It goes through several topics: leg ulcers, avascular necrosis, when to use your oxygen cylinder or concentrator. So there's just a lot of information there for you to use. Okay, so otherwise, apart from that, have you been able to post it here?
Yes, I'll put it in shortly.
Okay, let's see. Oh, Helen, do you have access to the link? Yeah. Let me look at the folder for that. Hold on. Should be in the discovery folder, I believe. We kept it there. Hold on. Let me know once you get it. I can, Helen. It's your. Okay, I see the link here. So hold on. Let me see if I can put in the chat. Okay, I just put a link to the handbook in the chat, so people are free to take a look at it, and you're free to use it. And I'll just share my screen to show you guys. how it looks like. So here is the sickle cell discovery handbook, and it has several different sections. The foundation, the specifications of oxygen, how malaria triggers sickle cell crisis, symptoms of sickle cell disease in a 6-month to 2 years old, priapism, leg ulcers, avascular necrosis, what to do when home oxygen doesn't work, management of crisis in a hospital, pulse oximetry and oxygen saturation, oxygen toxicity or side effects, workup of shortness of breath, case series about the discovery. So that is it. So, okay, so Isia, what is next on the, hold on. What was the next item on the agenda?
Next, we have an update on 1 year of donor oxygen support from Miss Cynthia Okeke of the Dagomo Foundation. I'll just unmute.
Okay. Hello, Cynthia, are you here?
Yes, I'm here, Dr. Sota. Thank you very much, Isua. Dr. Sota, I don't know if you'll be sharing my report or should I share my screen?
Share your screen.
Okay. Okay, can you see my screen, please?
Let's see.
Sorry, I didn't get that.
Yeah, I can see your screen.
Okay, thank you very much. Okay. So one of our key responsibilities we own to donors and partners is accountability. So every contribution made to this initiative represents trust, and it is our responsibility to ensure that trust is honored through transparent reporting and prudent stewardship. So it is therefore my privilege to present a summary of the donor funds received over the reporting period 2025 to 2026, how those funds have been utilized, and the impact they have made in the lives of people living with sickle cell disease. So let's begin with the overview of our performance. So this dashboard provides a snapshot of our overall performance during the reporting period. We received a total of 24.89 million in donations. Of this amount, approximately 17.79 million has been deployed directly towards program activities, while 7.10 million remains available to support ongoing and future interventions. So through these resources, we have directly supported 69 beneficiaries while achieving a procurement delivery rate of 97.1%, demonstrating our commitment to ensuring that donated resources are translated into timely support for beneficiaries. So moving ahead, this chart presents our fundraising performance across the reporting period. You will note that we have a 68% decline in donations for this year, 2026, compared to 2025. But I also want to note that 2025 reflects a full 12-month fundraising cycle, while 2026 represents donations received only to date. We remain optimistic about the months ahead, and we look forward to additional fundings and partnership as we continue expanding support for people living with sickle cell disease on our platform. Okay, so where the resources went to fund utilization. One of the key objectives of this initiative is ensuring that oxygen is readily available to warriors during emergency. So consistent with this objective, 80% of total program expenditure was directed towards the procurement of oxygen equipment, including oxygen cylinders and concentrators. So the remaining 20% supported medications, hospital bills, welfare assistance for beneficiaries facing urgent medical and financial challenges. So our current financial position as of now, from total donations of approximately 24.89 million, we have deployed over 17.79 million towards program activities. We currently maintain an available balance of approximately 7.10 million. So this balance positions us to continue responding to urgent requests while ensuring prudent financial management as additional funding opportunities are being pursued. So our procurement performance, one of the key indicators of the program effectiveness is how quickly donated resources reach the people they are intended to support. And I am pleased to report that we have achieved a 97.1 delivery rate. During the reporting period, 66 cylinders and 1 concentrator were successfully procured and delivered. So we have only 2 oxygen concentrators that remains outstanding, and it has been flagged for supplier follow-up. So this demonstrates our commitment not only to procurement, but also ensuring timely delivery to the beneficiaries. So the success of this initiative is simply not measured by the amount of money we have spent, but by the lives that we have impacted. So during this period, the reporting period 2025 to 2026 as of now, we have directly supported 69 individuals living with sickle cell diseases. These interventions included oxygen equipment, medications, hospital support, and welfare assistance. So behind every number is a real person, a warrior who received timely support, a family that found relief during a medical crisis, and renewed hope made available through the generosity of our donors. So coming to the end of my presentation. So this impact we have recorded so far over the period of from 2025 to 2026 has only been possible because of the generosity and trust of our donors and our partners and supporters on the SCD platform. But I would also like to note that the demand for assistance continues to exceed the resources that we have available. Every week, I receive requests from warriors and their families who urgently require oxygen, equipment, medications, hospital support, and emergency interventions. While we celebrate the lives that we have been able to reach, we also have a lot of people living with oxygen cylinders that are also still waiting for such help to also get to them. So I want to use this opportunity to invite us all to continue this journey with us through financial contributions, strategic partnership, advocacy, and referrals. Because I believe that together we can extend this hope, save more lives, and build a future where every person living with sickle cell disease can have access to timely care and the support they really need to live a life that is free from this pain that comes along with this sickle cell disease. So thank you very much. If there's any questions, I'm open to answering them.
Okay, so you can stop your screen share now. Thank you. Cynthia. Okay. So it's sure you can ask if there are any questions from the participants.
Yes, so now we have a brief time for Q&A or comments. Please try to limit your comments to 2 minutes, and you can use the raised hand function if you'd like to speak. And we already have one. Great. So Professor Nike Grange, you are welcome to speak, and I'll unmute you shortly.
Okay, thank you. Thank you very much. Honestly, I'm speaking again because I feel that we are all on the same on the same plane, the same level. That is to ensure that these children or adults as well, sickle cell patients, benefit optimally from Dr. Sota Omoigui's discovery. And I can see that that is what is happening. Thank you very much. The reason I brought in the issue of trials, etc., is to let you know that it is not necessary. I mean, I did say there that we didn't have to do trials before getting to the patients. However, whatever trials have been known, the reports should be made open so that we can raise the level of this discovery to the policy platform, policy and regulatory platform. And it's very important because what if somebody somewhere says, oh yes, I recommend oxygen, but comes out with adulterated oxygen? Who will monitor it? Who will tell him? Who will get accountability for that? So there are so many other issues that need to be looked into. I do not belittle at all the effort that Dr. Mogui has put into this. He has done fantastically well. And I forgot to even congratulate him for his birthday. Well done. I think we are on your side, but this is an underdeveloped country. It's not even developing, and any little thing that you think has been established and is going to be of benefit can be hijacked by anybody. And unless there is close monitoring by institutions, by the ministries, by various people who are responsible. For example, the CDC in America, but here we have the NCDC. They should know about this, and so everybody should be working concertedly. You've managed to get a lot of people to collaborate. Honestly, it's fantastic. There's money being contributed and all that, and there's accountability there. Thank you very much. It's really wonderful. It's such a fantastic program that I would not like it to be belittled or to be defrauded, because there's a lot of people who would like to take advantage of what you have found. And, before you say it, they have caused a lot of havoc among your patients because they've come out with something that is not genuine, that's not of good quality. So that is the reason I have said that, we need to look at the institutional arena that, these things, these trials are carried out. Even if they are not trials, if they are just observations and the reports are being, they must be brought together and published so that you said that there are so many publications and all. That is fine, but we have to take them to places where they can be monitored, and nobody should be able to hijack the basic principles that you've enunciated and you have worked on. It's a lot of work, I know, but we must work together so that nobody. I think I told you my story of the diarrheal oral rehydration. Lo and behold, the oral rehydration salts which were being sold became, they were being contaminated. But one of the ways we now said the mothers should start their rehydration is to make their own in the home, make their salt sugar solution. So we all need to look at various aspects of a discovery to make sure that there is, they are not being hijacked by charlatans. So
Okay,
I'm sorry if you feel that, I was still asking for, uh, I was still asking for the moon, for the earth and the moon to meet before, you start your study. No, before you start this work. No, I believe sincerely that you've done it the right way, but we must continue to monitor. Thank you.
Okay, thank you,
Mm.
Ma. I'll just respond to you briefly.
Mm.
You mentioned NCDC. This is not a special gas being used. It's the same oxygen used in the hospitals. Whatever NCDC can you put it on mute? Put everybody on mute if you are. Whatever however they are monitoring oxygen in the hospital, if NCDC is monitoring oxygen in the hospital, and I don't think they are free to check this. But this is not a special gas. The same oxygen that's used in the hospital. There's nothing special about this. That's just being used at home. That's number one. Number two, any hospitals, any facilities, any doctors who want to do studies, observational studies, they're all welcome. I'm not in Nigeria, but having to do this from the United States. But people who want to implement it and do it, all the information is on the website. They are welcome to do their studies. Nobody is holding anybody back. But most importantly, the patients are not going to wait for them and go into a vascular necrosis and acute chest syndrome and die and spend weeks in the hospital because nobody has taken the time to check it out. Everybody is welcome to check it out, but the work continues and what we are achieving continues. The patients are the ultimate arbiters of any intervention or discovery. So sure, you can go on to the next person.
Okay, next we have Helen Omoigui, who asked to speak earlier.
Hey, thank you, Siwa. Thank you, Siwa. I would like to use this opportunity to say thank you to everyone who has donated and to those who continue to donate to this cause. Thanks to those donations, families who do not have, the resources to purchase oxygen cylinders now have access to them. So thank you for your generosity. Thank you for your unwavering commitment. You are deeply, deeply appreciated. And I also want to use this opportunity to say this to my husband. As your wife, I've had the privilege of witnessing the passion, the commitment, the sacrifice, the unwavering faith behind this discovery. You saw a need in the world, and guess what you did? By the special grace of God, you step up and you decide to address that need. And I want you to know that you're deeply appreciated. You have brought renewed hope, to sickle cell patients and their families, So thank you, thank you, thank you. My prayer for you today, by the way, happy birthday. We celebrate your birthday today. And my prayer for you today is that the Lord continue to grant you good health, give you wisdom and guide you, and continue to increase your impact across the globe. So thank you for all you do, and thank everyone, for participating.
Yeah, thank you, Helen. When you use the term renewed hope, I hope people don't think I'm an APC member. Okay, so this is not renewed hope of APC. It's a renewed hope of oxygen. Okay, all right. Thank you for that. So, Isiwa, go ahead.
Next, we have Amina Zakari.
Yeah, good evening or good afternoon, depending on where you are. Thank you very much for having me speak. Congratulations, Dr. Soto, and happy birthday. Can't believe it's already 2 years and the impact is so high. I thought this had been going on for longer than 2 years. I would like to agree with Dr. Grange on the fact that this needs to be brought to the attention of a lot more agencies and people so that it can be accepted as a treatment protocol for sickle cell patients, especially those that are insured. This can be advanced to the insurance companies, the HMOs, so that they can encourage patients to have access to the oxygen rather than suffer hospitalization and more costs even to the insurance companies. And I also like a lot of interface with Federal Ministry of Health if it's possible for those that are influencers amongst us. And I would like to say that my son has been using the oxygen since November. And so far this year, we haven't been hospitalized through winter. He's had a hip replacement. He asked for oxygen right after surgery. He didn't have post-operative crisis, which would have been normal. And so far, he just has mild crisis at home. He uses his oxygen. Even this afternoon, I heard him using it. So far, so good. We'll say thank you. And we wish a lot more patients would be able to access the oxygen tank or the oxygen machines. I also like to ask Cynthia if through the donations they also provide oxygen machines, or is it just the oxygen cylinders that the social group provides? Thank you very much for listening, and congratulations once more.
Thank you. Thank you. Before Cynthia responds, thank you for your testimony. And yes, you say your son did a hip replacement, but now that he's using home oxygen, you know that that hip replacement is not going to fail. It's going to, as you've said, it's stopping the crisis, preventing the hospitalizations, and also all the other sequelae. So thank you for your testimony. Cynthia, please go ahead and respond.
Okay, thank you, Ms. Amina, for your feedback. So regarding what the foundation provide, it's actually oxygen cylinders. Due to the high cost of concentrators, we can't really afford giving out oxygen concentrators, except there is a special donation made for towards an individual for oxygen concentrators. Because when I was reporting, you notice that the number of concentrators that was procured or pending is just 3. And those 3, the donations came specifically for that purchase. So not from the foundation.
Okay, so thank you very much, Cynthia. So I mean, we have just very few donors, just trying to, even I have been contributing. My friends and my family all come together, my church members. Every month we contribute a little bit together, try and get a few cylinders. But this discovery needs to spread out to a whole lot more people. And like Amina said, insurance companies, it's much cheaper for them to get a home oxygen for their clients than to be paying for hospitalization and blood transfusion and surgeries and leg ulcers and avascular necrosis. Really, it's not rocket science. And also for the government. If you see the economic impact of sickle cell, you will know that a responsible government will offer to provide oxygen cylinders or concentrators to their citizens. My key word here is responsible, a government that has the response to its citizens. So that's all I can say. But yes, more people need to get on board this. I alone cannot do this. Everybody has to come along and do that. And I say, when Jesus Christ came, he had only 12 disciples. And now there are 1.4 billion Christians. So people have to come along and take this further. All right, thank you. So Isiwa, go ahead. Who else do you have to call?
And next, Dr. Mamudu would like to speak.
Can you hear me? Can you hear me?
Yes, we can hear you,
Okay,
Dr.
yeah. Thank you very much, Dr. Sota Omoigui, for the tremendous education. I have learned more about this whole thing today than ever before. For me, I was very properly educated. And I listened to everything. I was there from the beginning to the end. And I'm leaving better informed. Before now, I just saw clips of oxygen. I didn't quite get the grasp of everything. So I'm happy I attended. So I'm leaving with a lot more information. I agree entirely with Professor Grange, but I'll frame my concerns differently. And I'll focus on intellectual property rights. You see, you have put in so much, and I see a lot of your empathy. And I hear a lot of pro bono. But at some point, there has to be some accountability in that realm. There has to be, your rights as someone who has discovered these things must be protected. I'm sure there are also a number of patents because we are talking equipment, different things. So how are you ensuring that all these things are properly accounted for so that, according to Professor Grange, things are not hijacked? You have to understand that there's a preponderance of sickle cell anemia in Nigeria, in Africa. You don't find, they're not, this country is not, well, I live in the United States. The United States is not harassed by the scourge of sickle cell. It's not in their face like it is in Nigeria. So it's more of a Nigerian thing, So that takes me to how much partnerships do you have in Nigeria with our universities? And it takes me back to Drain Brain. This is a remarkable achievement, and we keep, how do we make this a Nigerian thing? The world can be really proud of this. Because honestly, I can tell you for free, right? If you're not intentional about protecting this, right, the West will take it, they will take it, and that's it. You'll be forgotten. But so you have to hold it and bring it back home because that's where you'll be truly appreciated.
Thank you, Dr. Momodu, for
happy birthday. Happy birthday.
Thank you.
Happy birthday again.
Thank you, Dr. Momodu. First of all, I'm very familiar with patents and intellectual property. I have like eight different patents filed and granted. You see, one of the reasons why the big pharma cannot subscribe to this discovery is because nobody can patent oxygen. Okay? If the person who holds a patent on oxygen is God, okay? Because you have oxygen in the air. So oxygen is not patentable, and that's fine by me, because the people who can least afford this are the people where sickle cell is predominant. You have like 4 to 5 million people in Nigeria and 100,000 just only in America. People can't afford to refill their cylinders, Dr. Momodu, for 15,000 naira. Look at the average income in Nigeria is 25 to 70,000 naira.
Yeah.
A cylinder in Nigeria is 190,000 and a refill is 15,000 naira.
Wow.
So somebody who's making 25,000 to 70,000 to go and buy a cylinder of 190,000 naira, that's like 2 or 3 times their income. So it's never going to happen. For those, and there are people there with 1, 2, 3, 4 children. Even after we bought a cylinder for a member of the platform, he couldn't even afford to refill it for 15,000 naira. So it's okay. My discovery can be free. There is no, I do not assert any intellectual property rights on it. It's open to everybody, any hospital, any doctor who can use it. It's the same oxygen hospitals use. In fact, the patients, when they want to use the oxygen, they go to the suppliers of the hospitals and get the oxygen from there. So there's no issue of, if it's going to be adulterated, it's going to be adulterated in the hospital as well, not just at home. So yes, our country is too poor. And you know the funny thing, Dr. Momodu, even when Pfizer was doing the Oxbrita, which was a remarkable development, do you know how much they were charging for Oxbrita? Do you know how much?
No.
$10,000 a month.
What?
Yes, before the drug was recalled. 10,000. Meanwhile, you have people who cannot even refill their cylinder for $10.
$10, yeah.
And the drug. So I'm happy that this discovery has come about in a way that's most accessible and most affordable. Should be, because we have a country that has 63% multidimensional poverty, Dr. Momodu.
Yeah.
People are poor, many of them.
Very, yeah.
You know, they've been put into poverty by successive governments. So what we need is people to join and donate, whether it's through the insurance company, whatever, and the government. This is not just a medical issue, this is an economic issue. This discovery can raise the GDP of Nigeria by 4.2% just by providing home oxygen to all sickle cell patients and increasing the productivity. Fathers don't have to be in the hospital instead of being at work or in their business. Mothers don't have to be in the hospital instead of being in the market and doing whatever they need. Children can be in school. All these sequelae can be minimized. But I want to tell you, there are many people out there who are not really enamored of this discovery because it disrupts their financial model. Because if they don't have crisis to be treating, they don't have donors to be giving them money to be treating leg ulcers for their foundations over and over, a revolving door of treatment, they are not interested. So we have to understand that those are the people that are going to resist, but that's okay. Every major discovery always have the people who will resist it to the very end. But the one people who know about this are the people who have used it, not just severally. The first time they use it, they know the impact. So it's free of charge to everybody, Dr. Momodu, and I hope you will join us in contributing $40 a month towards getting oxygen cylinders.
Well, I won't do that, but I'll just give $1 million.
Oh,
I'll give $1 million naira. Okay, a one-time donation of $1 million naira.
Thank you, Dr. Momodu. Cynthia, I will give you Dr. Momodu's information so you can send it. Everybody give Dr. Momodu a round of applause. And I want to tell you, Dr. Momodu, you'll be surprised the number of lives, the number of children you will save from their tears, their crying, their pain, their hospitalization.
It's evident. Yes, it's evident.
Thank you. Thank you very much.
Thank you, sir.
Yeah. All right. So if you want to go to the next person.
Okay, so we have no remaining hands, so we can proceed to concluding remarks by Ms. Cynthia Okeke.
Okay, Cynthia, please go ahead to conclude.
Okay, thank you so much. Thank you so much, Isowa. Hearing the feedback from Dr. Momomoto today shows today's event has been a success, because I know that we also have people on this platform that has gotten the clarity and better understanding of what the whole oxygen therapy is all about. So on behalf of Dr. Sota Omoigui and the Dagomo Foundation, I want to extend my sincere gratitude to our distinguished speakers for sharing your knowledge, your expertise, and experiences, because your insight have deepened the understanding of the whole golden half hour, and people have gotten the needed understanding and the knowledge they need to proceed with it. So thank you to our donors, to our partners, and our supporters for the journey so far. Thank you so much, and may God bless you all.
Okay, thank you, Cynthia. And I want to recognize our Rise TV correspondent who has joined us on this broadcast and who was the one on the Arise TV show. Ms. Turaya Farouk, thank you for being an advocate for publicizing this discovery. And we hope it can be publicized in more TV stations, more radio broadcasts, because the need is tremendous. So thank you, Turaya. And thank you, everybody, for attending. I know this went longer than expected, but the journey continues. Good night, everybody. Take care.
Thank
Bye.
you.
Sure.
Bye.
Today.